you mainly want when we start talking about collecting blood samples is to put it immediately into an EDTA tube so that it doesn't clot, so that the machine, the IDEX, can work appropriately on the sample. So you initially pull your blood, you put it into your EDTA, and then you apply the rest of the blood into like a serum separator. And once the serum separator has the blood, you actually have to let it sit and clot for about 20 minutes. And then you can spin it down for 10 minutes to achieve your serum. So once you have all of those, after the basic collection, what you're going to want on your form is the patient information, our hospital information, phone number, species, breed, all of that. And then from there, we will be able to package this up. This IDEX request form also has the tests that we're going to be running as well as the samples that we need. So when we apply our samples into our bag, they're going into a separate compartment. So our form is in here just in case anything spills, and then our samples are in the back. And then we're going to make sure that is padded well. And for that, we need to just use paper towels or newspapers. So we're able to just wrap this in some paper towels so that nothing gets broken during transport, and we would add it to our box. Once it's in our box, we put a cold pack in because our sample will get there within 24 hours. If it's over 24 hours, you do have to freeze the sample and pack it on dry ice. But for now, over 24 hours, the box will work. And that is how we prepare this for sending to the IDEX laboratory.
So to keep up with our microscope, you always want to focus your stage at the lowest position so that, and also on the lowest magnification so that there's the most space in between so nothing gets bumped or knocked out of place. My light, my illuminator is off. My eyepieces are as close together as they go, and then I take lens paper and distilled water or a lens solution cleaner to clean the actual parts of the microscope. I start with the base or the stage, and I'll just clean off any debris, anything left over from our samples with a whole sheet of lens paper, moving the slide holder and adjuster as I go, just so that I get the whole stage clean. And then move on to cleaning the lenses themselves, which are very delicate, so you want to use the lens paper. I start with the lowest magnification and just clean it slightly. And then with new pieces of the lens paper, I move up the magnification all the way to the oil immersion lens, just in case there's some excess oil on there. I'm not transferring it to the other lenses. And the ocular lenses. And then just with an alcohol wipe, I'll wipe any of the non-lens areas just to make sure that it's clean and that any dirty hands that might have touched it throughout the day, it's getting sanitized, especially on the base. At the end of the night, we then put our dust cover over it. We're going to be running a snap test for canine heartworm. So our snap ELISA test comes in these packages, and they have specific instructions. So we're going to be doing it per the instructions of this specific IDEX test. We have our conjugate, as well as our sample, our unclotted EDTA tube sample. This is an appropriate sample for this test. You do always want to check The ratio is 4 drops of conjugate to 3 drops of our whole unclotted blood. And I use the specific pipette that comes with the test. And that's 1, 2, 3 drops.
Blood work wise, the blood work doesn't look good. Meaning, there's no.
I then take our sample vial and I invert it a couple of times and pour it into the well of our snap test.
The kidney values are astronomically high, meaning kidneys are so inflamed.
I then allow our sample to run all the way through the test window and up into
Our red blood cell count is
our higher well, and once it hits that well, I'm able to snap the test down.
That's usually the sign of
I can also label our test while I'm waiting.
The other problem is that the pancreas is inflamed. Now, the reason the pancreas should be inflamed is because of blood pressure issues. So the blood pressure from heart disease, blood pressure.
If I get hit this window, I'm able to snap it completely down.
They're not going to do it. We can go on.
We are going to take an ear swab from Abby. So I'm going to hold up the top of the ear, and I'm going to take a clean cotton swab just in the external ear canal and twist it to get some cells, and it is a little bit painful. And I'm going to use another one on her right ear and do the same thing, just to get some cells from the external ear canal. Now I'm going to take my right swab and put it on an appropriate labeled slide and roll it so that the cells don't get damaged. So there's my right ear, and then with my left swab I'm going to do the same thing. I'm going to roll it onto the slide. And then because of all the wax, I will now have to heat fix this. It'll help to dissolve some of the wax so that we can see the cells a little bit easier, and then I'll show you the staining process. Today we are staining our ear cytology. Our ear cytology here is one of the items that we can heat fix, so we're going to heat fix it to dissolve some of the wax and aid in the staining procedure. We don't want to damage the cells though, so it's a very quick 3-step pass. 1, 2, 3. And then we will go over to our stain. Our stain is our Dip Quick, and it's got a fixative, a stain itself, and then a counter stain. And the way that this company or this manufacturer has their instructions online is 5 seconds each. So we start with our fixative, and we let it sit in there for 5 seconds. We then pull it out of the stain and let the excess drip off. And once most of that excess is off of the slide, we put it into our active stain for 5 more seconds. And then after that 5 seconds, we again allow it to drain the excess. And we move it over to our counter stain for another 5 seconds.
Just stand and just remind her if she's still here. Sedation X-rays on Thursday. Drop off.
We're then able to take this out of the stain, let the excess drip off, and then we pull it up to the sink where we wash with distilled water. And we just rinse gently with that distilled water
In general, if they're hurt,
and allow it to air dry.
we don't even have to worry about vaccines. If they bring it up, you can
I will then label it and write down what time I stained it, and I will read it once it's completely dry. When it comes to evaluating a sample under the microscope, you always want to start with the smallest objective lens, focus it, and then move on from there until you reach the objective that you need to be able to see what you're looking at. So with this ear cytology today, I start with my lowest objective and I just focus it. I find the lowest left corner of the the sample, and I just get it roughly focused, and then I'll move up to my second objective lens and focus that and just see what I can see. And from there, I like to go up to the third objective lens, and that gets me a good idea of what organisms and bacteria I'm dealing with. So from there, I just make a grid motion. So I start at my bottom left, I go up, and then over one field of view down until you reach the other opposite corner. That way I can see everything in the sample, and I'm getting a good idea of what's going on. And if I ever don't have enough light or it's not bright enough, I can adjust my light source as well. In this sample, particularly from this dog's ears, I'm already noticing some cocci bacteria, a little bit of yeast, and also some rod bacteria. For our necropsy today, we are gowning up in removable and disposable gowns, gloves, face mask, as well as eye goggles. We also have 10% neutral buffered formalin for our biopsies. And then as far as the procedure itself, Dr. Cobbington will walk us through it and we'll collect some samples. We also have disposable scalpel blades, and we're in an area that's well ventilated with good drainage that we can clean easily, and it's separate from our regular surgical suite.
Okay. So first thing we're going to do is we're going to make a incision from the pelvis all the way to the stomach, and then we will make sure that we can eventually release Megan's hand. So I'm going to make incisions on the legs so that we can keep the patient nice and spread out.
I want to walk with Hendrix. How do you want to do that? Hendrix is the
Really? My bag is full.
Oh, is it? I found another incubator too. Or I got one and left it up. It's only good for 3 uses.
Yeah, I had that one. I hatched an egg. There's like a 5 millimeter egg.
On whirl or wag?
Wait,
So as I look at my samples, my organs, I want to make sure that everything else looks okay, seems okay. And then here in a second, we will get a sample from the liver, which is up here. And of course, what Megan's going to have to do for me is, once I get my sample, we'll have to put it in the histopath bottle into the formalin, so it will be sent off for analysis.
When we get a sample for histopathology, we want about a 1 to 10 ratio of sample to formalin when we package and send off. We're discussing the rabies procedure and how to take samples from a rabies suspect and properly protect ourselves. The most important thing is knowing how to handle a suspect like that, and having the vaccines to protect yourself first and foremost. You should be wearing goggles, a face mask, double gloves, and with especially larger animals, an apron, rubber boots, and potentially a face shield if necessary. From there, you basically take the head off, leaving the brainstem intact. With a disposable knife or scalpel blade, you would then throw the scalpel blade or the disposable knife in the sharps container, double bag the head, and pack it on ice and send it to the local lab. The body would be double bagged and put into a red biohazard bag and labeled as a rabies suspect. And from there, disinfection of the treatment table, all of the utensils with a proper cleaning agent like bleach,
and disposal of all of the gloves and the suits and the masks into a red biohazard bag as well. And that is how proper samples are taken from a rabies suspect. Okay, today we are going to do a vaginal cytology on Chloe. I'm going to lift the tail so that I can get access to her vulva area. I'm going to gently separate while I insert the Q-tip at a 45-degree angle. This is to make sure that we're not entering the urethra. Once I am past the vulva and I hit the sphincter, and it seems to be kind of stopped, I'll then elevate my swab parallel to the table and gently progress that into the vagina while I rotate it to collect the cells. I will then gently pull that back out and take it over to my slide. Now once I'm at my slide, I will take it and roll it so the cells do not get damaged.
Running on the top, jumping that in the top of the
And once I do 3 parallel lines, I will fix it with our commercial fixative spray and then allow it to air dry.
I mean, we've gone.
We're now going to stain our vaginal cytology. We're using the Dip Quick staining technique. It gives very similar results to the GIMSA technique. Ours specifically, the manufacturer has 5 seconds in each one of our fixative, our stain, and then our counter stain. We're not heat fixing a sample like this, it would damage the cells, but we did use the fixative spray, the commercial fixative spray. So I'm going to dip it into our initial fixative for 5 seconds. I'll let the excess fat drain off per manufacturer's instructions, and then into the primary stain for 5 seconds. I'll let the excess of that drain off, and then I'll put it into our counter stain for 5 seconds. And once that one's complete, we can gently rinse with distilled water.
And here.
And once we have that, we will allow it to air dry. You can blot it with a paper towel, just slightly. I usually just lay a paper towel over it and let that absorb any excess moisture, and then allow it to air dry. As I look for the different cells in a vaginal cytology, I'm focusing on parabasal cells, looking at the absence or presence of red blood cells, white blood cells, mucus, debris, as well as epithelial cells. And from all of that, I can determine what stage of estrus I'm in, and I will then do my grid pattern throughout, noting what I'm seeing. Initially, I see epithelial cells. I'm not seeing a whole lot of debris or mucus. In these epithelial cells, I'm also seeing an equal amount of parabasal cells.
So this one is the preventative package without the blood work. It does
And
do
with the lack of
small
debris
CBC,
and mucus and blood,
to say.
I don't believe I'm in
I'll say it.
proestrus.
Yeah, or we can do the big one, and that is like sick-borne diseases, liver, kidneys, any kind of infection. All
Parabasal cells that I'm seeing
I think that is one.
cancel out the idea that we're in estrus. So what we have here is our cross-matching. We have our serum that has already been sitting for 20 minutes and spinning for 10 minutes of our recipient, and then our EDTA recipient as well. And then we have our donor serum and our donor recipient EDTA. We have not spun the EDTA yet. As of right now, we are just basically going to centrifuge the EDTA tubes. So I'm going to place these in the centrifuge. And then once those have spun down, I will decant the plasma into
to our 2 disposable test tubes that I will also label as donor and recipient. As our EDTA tubes are in the centrifuge, I'll just transfer our donor serum over to our red top tube. I'll do the same thing for our recipient serum. After decanting the plasma from the EDTA tubes, I will be taking 2 drops of the erythrocytes and placing it into our test tube. And I will also take 2 drops of our recipient's erythrocytes. Now I'll place those into our test tube. I will then fill the rest of the test tube with 0.9% sodium chloride. And we will spin that for 1 minute at 3,400 RPM to wash the erythrocytes. We'll do that a total of 3 times. Once our erythrocytes are washed the first time, we will remove the tube, remove the supernate, and then wash the erythrocytes again. So as you can see, our erythrocytes are down at the bottom, while all of our supernate is at the top. That is what we will be removing. We will continue to wash 2 additional times. So that has been removed. I will then add more sodium chloride to do an additional wash. So wash number 2 for our donor, and I will then remove the same supernate from our recipient and add another dose of the sodium chloride. So that supernate's been removed. I'll add the sodium chloride again. Spin for another minute at 3,500 RPM. I'll do the same procedure over. I will do that 3 total times, and then at the end of that, we will move on to the next part. Our washed erythrocytes have been washed 3 times. They are sitting in the centrifuge, but before I grab those, I'm going to add 0.98 mils of saline to each of these mini tubes to make our 2% erythrocyte suspension. So 0.98 is in there. I also have a syringe to get out our washed erythrocytes. After 3 runs, our supernate is completely clear. We will remove that, and then what's left at the bottom are our washed erythrocytes. our recipients, we'll do the same thing.
.02 mLs.
Of washed erythrocytes. And place that into our sample cup. And that is our 2% suspension of erythrocytes. 2 drops of the recipient serum. With 2 drops of the donor cells. And then with our minor cross match, we're going to do 2 drops of the donor serum. With 2 drops of the recipient cells. And then we'll also set up our controls. Our controls are the same, so donor cells, with our donor serum, and recipient cells. Our recipient serum. We will let these incubate for 30 minutes. We will then centrifuge them and look for signs of agglutination. Okay, so our samples have now been incubating for 30 minutes. We are going to centrifuge all of them and then check for any signs of hemolysis or autoagglutination. Now that we have everything out of the centrifuge, we just want to check and see for hemolysis or agglutination. All of my erythrocytes are clustered here, and then my supernatant looks relatively clear. There's a pinkish hue to it that I'll detect a little bit more under the microscope. I'm gonna tap it gently to kind of mix it up. And that was our control. Our other control looks very similar. All of the erythrocytes clustered in this corner, and then our supernatant looks relatively clear. I'm not seeing any large clusters. And as far as our minor cross match, it looks very similar to our controls. All of the erythrocytes clustered here, and then as we tap, just checking for agglutination. And then our major cross match, again very similar. All of the erythrocytes clustered in one. That one, when mixed, It was a little questionable, but we'll check it under the microscope. So now we'll take each of these and check them under the microscope and go from there. We will begin checking for agglutination with the microscope with our controls. I'm going to put it in alphabetical order, so our donor control is going to go on the left side. And our recipient control is going to go on the right side. And what we're checking for is just the even distribution of erythrocytes, no abnormal clotting or disbursement. We're going to lower our condenser. Corner and just look for any abnormal clusters. So far everything's dispersed. You can easily see my erythrocytes, but none of them are clustering or forming together. All of my erythrocytes are the appropriate size, shape. No abnormalities noted so far. Now in the corner of these slides there is a little bit of clustering, but it's kind of where all of the edges go together and you can see them moving through the fluid. So everything's just kind of getting caught in the currents. My memory card became full during the microscopic evaluation of our matches. What we noticed though was that the controls did not show any signs of hemolysis or agglutination. Neither did our minor cross-match, showing that they are compatible. However, when we were looking at our major cross-match, there were about 8 clusters per field of agglutination. So there was about 15 erythrocytes per cluster, and like I said, about 8 to 10 per view, and we deemed that incompatible for transfusion, and we recommended getting a new patient and trying this over again. So for this skin scrape on a possible main, I'm actually going to pull in this case. I'm going to go for the lesions that are pretty severe, and I'm going to go just on the outside of them where the mites might be. I'm going to take my scalpel blade, and I have 2 slides here with mineral oil added to the top of them. I'm going to slightly dip my blade in the mineral oil, and I'm going to scrape perpendicular to the wounds just until blood oozes from this way. Just until blood kind of starts to pool and the capillaries burst a little bit. Nothing excessive, but you do need a little bit of bleeding. Once I see a little bit of blood, I'll take what's on my scalpel blade and I'll add it to my slide of mineral oil. So now that I have that, I will come over here and scrape it onto my slide, and I'll then apply a cover slip. And I like to do 2. Sometimes you need to clip the hair, but in this case, it's not necessary. When we look at skin scrapings, we're just scanning the slide, so we can go to the 4X and then find the corner of our cover slip, and we'll just do our grid pattern as always. As we're going through, we want to adjust our fine focus back and forth slightly so that we see all of the levels in between the mineral oil. Sometimes with the mineral oil being so thick and viscous, it camouflages certain aspects of the slide. And then what we're looking for are just mange mites. So any species, any legs, body parts, You don't necessarily need to see the whole thing, you're just noting any foreign mite that you find. This dog has been on next guard for a few months for demodectic mange. We're hoping to see either some dead ones or none at all. As we scan through, we're really focusing on those clusters of hair and skin cells and in between the layers to make sure we're not missing anything. In this slide, I've seen one demodectic mange mite, but it was dead. It was a lot smaller than a normal mite, and it looked a little bit like dehydrated. Sometimes I go through it a second time just to make sure I didn't miss anything. And that is kind of how we evaluate skin scrapings. And with demodectic mange and the treatment that we've already started, we'll just go from there.